I'm Haresh Mehta, Director Cardiology SL Raija Fortis Hospital and Consultant Interventional Cardiologist at PD Hinduja Hospital and Sir HN Reliance Hospital. My talk for today is about coronary protection and coronary access after transcatheter aortic valve implantation. So why are we so bothered about coronary protection and coronary intervention in aortic stenosis? So whenever we have aortic stenosis, 40 to 70% of these patients who have aortic stenosis will have concomitant coronary artery disease. And this coronary artery disease will need treatment either during TAVI, pre-TAVI or post-TAVI. So it's our responsibility as we move to younger and lower risk patients for TAVI, we will need these patients to undergo coronary intervention in future. So we have to design our procedure or TAVI procedure as per these requirements. And this is the crux of today's talk. So what do we do to avoid coronary occlusions and how do we access coronary arteries in these patients after TAVI? So one is planning of the cases. All these cases have to be pre-planned before they are taken for TAVI onto the cath lab. So you have to analyze your CT scan absolutely minutely to look for where the coronary arteries are going to arise from, what are the sinus sizes, what is the size of the valve you're going to use, what is the frame of the valve you're going to use, what is the height of the skirt of the valve, what is the STJ, the sinotubular junction diameter, and what is the risk of coronary occlusion when you put these valves. And of course, once we put this valve, we have to put these valves so that the commissure posts don't come near the coronary arteries. That means you have to commissurally align this valve so that the coronaries are separate from the posts of the commissures. Once you plan this, you can then deploy the valve. Of course, this is not 100% foolproof. After putting these valves, if these patients in future develop coronary artery disease, then we should know the techniques how to engage these coronary arteries through these valves. Of course, with a self-expanding valve, it may be more challenging than the balloon expanding valve. But we as interventionists have to learn these techniques to know how to treat these patients. For these patients are going to be a reality in the future. So that's the crux of my talk today.